Hey everyone, welcome back to Coursetta Nursing. My name is Will Kirkpatrick. I'm a nursing educator inside the Coursetta Nursing membership. Today we're going to go over Myasthenia Gravis versus Guillain-Barré. We're going to go over the pathophysiology, the signs and symptoms, risk factors, complications, and the nursing management of each. And we're going to compare them side by side. So that way you don't get confused with your next nursing exam. Although you will likely not see myasthenia gravis and Guillain-Barré very often in the clinical field, the NCLEX and the nursing exams love to ask about these two diseases, and we need to know the difference between the two. Before we get into the details about either one, it's important to note that both of these are autoimmune neurological disorders. So it is the deterioration of the neurological system in general. So let's first talk about the pathophysiology. So we're going to first talk about the myasthenia gravis and then compare it with Guillain-Barré. So myasthenia gravis, what is the pathophysiology? So first off, once again, myasthenia gravis is an autoimmune disorder that attacks the neurological system. Specifically, it attacks the acetylcholine receptors. And a lot of times this is genetic and it is usually involved with the thymus abnormality. So how it starts is there's blood cells and the thymus gland itself produces antibodies. And those antibodies can damage the neuroreceptors that we have, especially the acetylcholine receptors. Now, if you don't know, acetylcholine is a neurotransmitter that communicates to the peripheral nervous system to contract muscles, and that includes not just your peripheral muscles, but also your diaphragm. And if you don't know already, the diaphragm is a significant muscle that is needed for respiration activity. So of course, if that goes weak, then it's not a good thing. So those antibodies attack the acetylcholine receptors, which decreases communication to those muscles. So when there is a failure of communication to those muscles, it not only weakens them, but it also fatigues them. So it's easily fatigued. This, of course, when there is an increased need of muscle activity, such as when you're exercising, these patients get easily fatigued, so they would fatigue much faster than a normal patient would. And it's not just exercise, it's absolutely everything. So any small task that you can think about, just picking up objects, these patients are going to have a much harder time to maintain endurance. So they're going to easily fatigue. But out of the pathophysiology, one of the most important notes that you must write down is that myasthenia gravis is from the head down. It descends down the body. So you're more likely to get weakness starting in the face, and then it just descends downward. And of course, once it reaches your diaphragm, you're going to have some breathing issues. That is definitely one that you want to write down, because when we start comparing Guillain-Barré, there's a significant difference in the pathophysiology. So there are three key takeaways that I want you to remember about the pathophysiology of myasthenia gravis. Number one, it's an autoimmune attack on the acetylcholine receptors. And that acetylcholine, once again, is the neurotransmitter that communicates to the peripheral nervous system to stimulate muscle contractions and relaxation. Number two, this disease is progressive and it causes muscle weakness and increased muscle fatigue. And then lastly, myasthenia gravis is weakness or paralysis that can happen from the head going down. So the weakness descends downward. All right, so let's compare the pathophysiology with Guillain-Barré now. So Guillain-Barré is also an autoimmune disorder that attacks the peripheral nervous system. It specifically causes demyelination of the peripheral nerves. And once again, it impairs the nerve communication to those peripheral nervous system. The key takeaway with Guillain-Barré, though, is that it is weakness or paralysis that starts from the ground up. So it ascends. So we talked about how myasthenia gravis is descending paralysis. Well, Guillain-Barré is ascending paralysis. One way I'd like you to think of it is that Guillain-Barré starts with a G, and then you can think that the paralysis starts ground up. So it also starts with a G. And then once again, if that paralysis reaches the diaphragm, once again, a muscle important for respiration activity, then it could cause respiratory failure. Hey guys, it's Will Kirkpatrick, nursing educator inside Coursetta. I wanted to let you guys know that I will help you with anything you need at any time if you just send me a text at 940-218-4062, 940-218-4062. Let's get back to the video. All right, so let's get into those signs and symptoms of myasthenia gravis versus Guillain-Barré. The signs and symptoms are directly related to the pathophysiology, so try to make the ties in with what we just talked about. So myasthenia gravis, we talked about how it's descending weakness or paralysis, and it usually starts in the head. So what are some signs and symptoms that you may expect with myasthenia gravis patients? Two hallmark signs that you would want to write down that are commonly questioned about on nursing exams in the NCLEX is ptosis and diplopia. So your eyes. So ptosis is eye drooping, so they can barely keep their eyes open, and diplopia is double vision. Those are hallmark signs of myasthenia gravis. And then once again, myasthenia gravis is related to acetylcholine. So once acetylcholine is deficient in transmitting that energy to the muscle, they're easily fatigued with just normal activity. So you're going to see some signs and symptoms such as muscle weakness and fatigability. Another sign that this could be myasthenia gravis is that it improves after rest. And once again, going with the descending weakness and paralysis, what other muscles are important up here? It is your swallowing. So you could have dysphagia or dysarthria. So difficult swallowing and difficult talking. It can also make some changes to the face. There's something called the myasthenic sneer, which is a rise of the mid-lip. And these patients may have mask-like expressions. Since the muscles in the face are very weak, they can't really express emotion like we do with our nonverbal communication. And then, of course, just like the pathophysiology, a sign and symptom is descending weakness. So if you have a case scenario where a nursing exam gives you, where there's a patient who has mask-like expression and they're noticing that their weakness is going down the body, then of course, think myasthenia gravis. All right, so going over back to Guillain-Barré. So once again, what's the hallmark sign and symptom that they like to ask about? It is ascending weakness. So paresthesia in the feet is usually one of those first signs and symptoms of Guillain-Barré because it starts from the ground up. So you're likely going to see it in the legs first in Guillain-Barré, and the face first with myasthenia gravis. So paresthesia of the lower extremities is a common initial sign and symptom of Guillain-Barré, and eventually it progresses to weakness and then paralysis. And of course, if the Guillain-Barré progresses all the way up to the face, it can cause those same things such as facial drooping and dysphagia. But a common sign and symptom, and also included as a complication, is respiratory distress because of the impact it can make on the diaphragm. All right, so let's go over the risk factors and complications of myasthenia gravis. Earlier, we talked about how myasthenia gravis and Guillain-Barré is related to genetics. Well, once again, one of those risk factors is family history. And females are more likely to have myasthenia gravis than males. And anybody who is under the age of 40 or over the age of 60 is more likely to get a diagnosis of myasthenia gravis. Now, the complications is something that NCLEX and the nursing exams love to ask about. They want you to know about myasthenic crisis. This is one of those complications of myasthenia gravis. Don't overcomplicate it. The major indication of a myasthenic crisis is that it's pretty much just respiratory failure. That weakness or paralysis has reached the diaphragm and it's causing deoxygenation and decreased ventilation, so respiratory failure, because the diaphragm is weak. Now, another complication that you'll want to know about, specifically with myasthenia gravis, is the cholinergic crisis. We talked about how acetylcholine is associated with it, that there's not enough transmission to those acetylcholine receptors. So a common medication to manage this condition is acetylcholinesterase inhibitors, which decreases the breakdown of acetylcholine, basically making acetylcholine live longer. So that way it's not wasted as much and gives more endurance to the patient. Well, the risk with that is that we might have an acetylcholine overdose, basically, which can cause a cholinergic crisis. Some common signs and symptoms of cholinergic crisis is hypotension, bradycardia, bronchospasms, hypersalivation, miosis, which is constricted pupils, vomiting and diarrhea, and diaphoresis. Another complication that you may see with these patients, since they have dysphagia, that puts them at risk for aspiration. So you might see these patients have pneumonia or other lung complications going on, not just with the diaphragm, but also with these things such as pneumonia. Now let's go over the risk factors and complications of Guillain-Barré. So once again, this is an autoimmune disorder, but is less likely to be hereditary, such as like with myasthenia gravis. Guillain-Barré is typically related to an event such as a recent viral illness that caused this, or a flu vaccine is a possible cause, a Zika viral infection as well. And then lastly, conditions such as diabetes and cancer make it more likely that you would get an event such as Guillain-Barré. Of course, what are the complications? Now, myasthenia gravis, we talked about how the complications are myasthenic crisis and cholinergic crisis because it relates to building up of fatigue, which eventually causes absolute weakness, which is pretty similar to paralysis. But Guillain-Barré, the main complication is this complete paralysis that's progressive, and a lot of the times it causes permanent residual weakness. It doesn't recover like a myasthenia gravis would after rest. So because of that, the major complication is respiratory failure because of the shutdown of the diaphragm. And then once again, just like myasthenia gravis with the dysphagia, these patients are also at risk for dysphagia, and they might get aspiration pneumonia. Some other complications of the paralysis, since they are completely immobile, you're at risk for paralytic ileus, and of course urinary retention as well. All right, so let's get into the diagnostics. So the main test that confirms myasthenia gravis is related to acetylcholine. So there's an antibody test that we can do, which is literally called anti-acetylcholine. If they are positive for that, that means it confirms myasthenia gravis. Another test we can do is actually using the treatment medication, such as acetylcholinesterase inhibitors. The result would point to myasthenia gravis if the muscle weakness improves after giving this medication. Now with Guillain-Barré, we have to get a lot more invasive, so a lot of the times it requires a lumbar puncture to see if there's protein that is increased in the CSF. Some other things may be elevated, such as your inflammation markers, such as your ESR. All right, so we are on our last section, including the nursing management of both these conditions. Now, of course, we're going to start with myasthenia gravis again. So as we talked about earlier, one of the main medications that we will treat this condition with is acetylcholinesterase inhibitors. So once again, it keeps acetylcholine alive and it helps reduce the breakdown of acetylcholine. But one of the most primary treatments for this is plasmapheresis, because it actually removes the antibodies that are causing this in the first place, damaging the acetylcholine receptors. Some other things that may help to reduce inflammation, we'll use corticosteroids. And of course, if they suffered from aspiration pneumonia, we would be giving them antibiotics to treat that lung condition. But speaking management-wise, the nursing exams and the NCLEX love to test your knowledge on your ability to understand acetylcholinesterase inhibitors. And you must be able to identify them. So know that the common suffix for these medications is stigmine, such as pyridostigmine. And make sure that you know that one of the adverse effects of these medication classes is the cholinergic crisis. So what are those bedside interventions that we must do as nurses that they may ask about on the nursing exams? Is the head of bed must be 30 to 45 degrees. Why? Well, that limits the chances of aspiration pneumonia. We want to promote frequent rest periods because these patients get fatigued very easily. And we don't want to allow a myasthenia gravis patient get to the point of complete exhaustion because it's a lot different for them than it would be for us because they do not recover as well as we do. Small frequent meals is typically required because these patients, once again, it requires a lot of energy for them to do simple tasks. And then of course, lastly, is monitoring that airway and monitoring the respiratory system, as that is the most at risk organ in the body with myasthenia gravis. So we're going to finish this course up with the management of Guillain-Barré. So the primary treatment for this is also plasmapheresis because once again, it removes those antibodies attacking the peripheral nervous system. Another common treatment that these patients will get is IV immune globulins. And since these patients are typically completely paralyzed and they're immobile, they're at risk for DVT. So we're going to give them DVT prophylaxis medications such as a heparin or a Lovenox. What are those bedside interventions? Once again, head of bed must be 30 to 45 degrees to prevent aspiration pneumonia. Oxygen supplementation is typically needed because of the attack on the diaphragm. Anything that we can use to strengthen that diaphragm, such as coughing and deep breathing and symptom spirometry, is typically recommended. And of course, lastly, monitor that airway and monitor that respiratory system. All right, guys, that concludes the course of myasthenia gravis versus Guillain-Barré. We went over everything such as the pathophysiology, signs and symptoms, risk factors, complications, diagnostics, and then lastly, management. I hope this course helped you guys understand the differences between the two, so that way you guys can do better on your next nursing exam. Thank you guys so much for watching, and we'll see you in the next video. Hey guys, first of all, thank you so much for watching the video entirely through. It makes our day if we know that nursing school got a little bit easier after watching one of our videos. If you guys like this video, make sure you like it, subscribe to the channel for more, and drop down in the comments for any more ideas that you need help with nursing school. If you want to contact me personally, it's 940-218-4062. Thank you guys for watching. We'll see you in the next video.